Okay, Assalamualaikum and hello everyone. Thank you for joining us today. So I'll be talking about the point of care ultrasound assessment on fluid responsiveness. We'll go through two main parts. The first one going to be some basic foundation on the physiology, and then next we'll move on to the more practical part on how to use the ultrasound in our clinical practice. Okay. So when the patient in shock, basically there's a reduce in cardiac output and tissue hypoperfusion. So the main aim of a fluid resuscitation is basically to improve cardiac output and ultimately tissue oxygen delivery as to prevent or even to treat any organ dysfunction. So as we can see here from hemodynamic equation, the delivery of oxygen to the tissue mainly depends on the oxygen content in the arterial blood and also cardiac output. Okay, and the cardiac output is a product of a stroke volume and the heart rate, which is mainly the amount of blood being delivered to the tissue in a minute. So together with systemic vascular resistance and cardiac output, these two will determine our mean arterial pressure or the blood pressure lah. Okay, so by giving fluid, we are essentially increasing the preload and next the stroke volume, and we'll then increase the cardiac output and subsequently the blood pressure. So however, not all patients are fluid responsive because many studies have shown that only about 50% of the patient responds to the fluids given. So why is that so? So let's have a quick look on this curve. This is the Frank-Starling curve. So based on this curve, we can see that the higher the preload generally will increase the stroke volume. But we also notice that the relationship between the preload and the stroke volume here is not linear. Rather, we have a curve with a steep part and also the flat part. So when we say that the patient is fluid responsive, basically they are in the steep part of the curve, okay, whereby by giving fluid, it will increase the preload and it will increase the stroke volume, subsequently the cardiac output and the blood pressure. Okay, and those who are not fluid responsive, mainly they are at the flat part of the curve here, okay, by means that giving fluid bolus or fluid challenge doesn't really has a significant increase in the stroke volume as well as the cardiac output and the blood pressure. Okay, this is mainly because of the other determinants of the stroke volume, which is also determined by the contractility of the heart. Some patients have poor heart contraction, yeah. So, but when we say that the patient is fluid unresponsive, it doesn't mean that they doesn't need fluid. It's just that they need other means to improve the blood pressure, such as giving the inotropes or vasopressor. Okay. So the more important, so bear in mind those patients who are in the steep part of the curve are fluid responsive and they should receive fluid administration. Okay. So so fluid resuscitation, as you can see, can be depicted in this picture. Is a balancing act. We need to be just right to get the optimal tissue perfusion. Too little fluid will lead to organ hypoperfusion. Too much of fluid can lead to fluid overload, pulmonary edema, and respiratory compromise. And these two both extremes will lead to increase in morbidity and mortality of the patient. Yes, in some situations, is it difficult to differentiate between who will benefit from more fluid or who will not benefit from it? Okay. All right. So how do we evaluate fluid responsiveness? Generally, we have two parameters. We have static parameters and dynamic parameters. In clinical practice, there's no standard reference or gold standard. However, we have moved away from static parameters such as central venous pressure or pulmonary capillary pressure, okay, because growing consensus shows that they are poor predictors of intravascular volume. So in dynamic parameters, they are actually based on two ways to improve the stroke volume and cardiac output, mainly the passive leg raising and also the respiratory variation. Yeah. And in this topic, I will focus more on the IVC diameter variation. So briefly about the IVC, or inferior vena cava anatomy and physiology, we know that the IVC is the major means of venous return, which drains the blood to the heart, to the right atrium. And the vessels of the IVC actually change during respiration. It contracts and dilates, correspond to the respiration. And the change in diameter will reflect the change in pressure. Okay. So when we talk about IVC or inferior vena cava respiratory variation, okay, we divide into spontaneously breathing patient and ventilated patient. In spontaneously breathing patient, okay, how does the variation occurs during respiration? First of all, we have to remember when we inspire, when we breathe in, the pressure in the thoracic cavity will become more negative, okay, as to allow the air as well as the oxygen to be sucked into the lungs. So this will lead to negative intrathoracic pressure, which then will draw blood, to the from the IVC to the right atrium. So the effect of the drawing of blood from the IVC into the right atrium will result in transient collapse of the IVC diameter. So here during inspiration, we can say that the IVC size is at the minimum, whereby during expiration, the IVC size is at the maximum. So what about ventilated patient? So in a patient who is ventilated, when ventilator is essentially giving positive pressure as to push in the air and oxygen into the patient's lung, in term we call insufflation. So we are essentially increasing the intrathoracic pressure, making it more positive. Okay, so some of the positive pressure will be transmitted to the right atrium and then down to the inferior vena cava, making the IVC's diameter more distended. Okay, so as opposed to the spontaneously breathing patient, the reverse happened here. The IVC diameter is maximum during insufflation and minimum during expiration. So I believe that some of you are, very familiar later with the IVC index terms, collapsibility index and distensibility index. So when we talk about collapsibility, meaning we are talking about spontaneously breathing patient, whereby distensibility mainly for the ventilated patient. Okay. All right, so the respiratory variation in the IVC diameter actually exaggerated when we have low intravascular volume and is attenuated in overloaded system or when the ventricle is failing. The respiratory variation will be observed only when the right atrial pressure is not high. So in this case, it will indicate preload dependent. So therefore, IVC respiration variation can be used to predict response to fluid challenge. In fluid responsive patient, respiratory variation of the IVC diameter will reduce after fluid administration, meaning that the variation during inspiration and expiration will be less and they will be more uniform. Okay, let's have a look at the clip on the normal IVC. Okay, as we can see here, the IVC diameter is less than 50%. It's neither flat or it's not distended. Okay. In hypovolemia, we can see that this is the IVC liver, and this is the right atrium. The IVC diameter here is flat. Okay, we call it flat IVC. Is almost collapsed. So we can see that it's more than 50% collapse. Okay, so after fluid administration, we can see here it become more distended and the variation is less. Okay, so usually flat IVC is just hypovolemia. What about the fat or plethoric or obese IVC lah? So in fat IVC, Can we only say is hypervolemia? No, so because we do have other causes of clitoral IVC, such as tension pneumothorax, massive PE, or pericardial tamponade. Okay, so fat IVC doesn't always means hypervolemia. Okay. All right, so now we'll move on to the next part, using ultrasound to assist in clinical decision. So remember, my aim here is we are not, radiologists. So our aim to know about this is mainly to estimate by eyeballing, spotting the extremes, whether fat or flat, rather than getting a very accurate measurement. So the use of ultrasound in this topic is actually quite controversial, but it is still used to assist in clinical decision. It is quick, it's very portable, and and it can actually provide a lot of information, especially when we have more and more knowledge on this. But remember, especially for beginners, it's only an estimation and it's very largely operator dependent. So the most important is to put into correct clinical context for our patient. Let's say if we have, a patient which is clinically not suggestive of one thing, but the ultrasound shows otherwise, always go clinical. So before I move on, a brief introduction on the ultrasound. The probe, so which probe to use? We have three most commonly used probe. We have linear probe, curvilinear, and phase array, also known as cardiac probe. So these three probes can be classified into high frequency and low frequency probe. So the high frequency probe means that they travel more superficial. So the penetration towards the deeper structure is actually poor, but they give the best image quality. Whereby for low frequency probes such as curvilinear and cardiac probe, they can travel further down and deeper to the structure, but at the same time they may compromise the image quality and clarity. So for fluid responsiveness, we will use mainly the low frequency probes. Okay. And also important to note that we have to know where is the point of the probe, which is generally whether any ridge, indentation, or groove at the sides of the probe. Only cardiac probe usually have the pointer at the right side, whereby the other usually at the left side. And this pointer will correspond to the image on the screen, ultrasound screen. Okay. Now, how do we get the best view? How do we optimize the view? So the basic principles mainly relies on the probe movement, adjusting the depth of the field. Okay, we don't want the structure to be too near or too far as not to compromise the surrounding structures, and then adjusting the gain, not too bright or not too dark, and also adjusting the focus point. And especially for the probe movement, I would say that this is very, very important, on how to manipulate the probe as to get the best view. Try to move in very tiny micro movement, to get the best image. Okay. Okay. So for to scan for the IVC using the cardiac probe, basically we put the patient in supine position, and then we use cardiac probe with the probe placed at the subxiphoid region, and the pointer will pointing towards the patient head, and we tilt up, okay, and aim towards the right, okay, aim towards the right, as we know that the IVC will lies there, and try to identify these three main structures. First is the liver, and then the IVC and the hepatic vein, before we try to interpret lah. And one thing that may confuse is whether this is IVC or aorta. Take note that that IVC will drain into the right atrium, whereby aorta will not. Okay. So we also can use a curvilinear probe. we can straight away jump into the longitudinal view, or we can start off with the transverse view. If we start off with the transverse view again, we place the probe at the subxiphoid region. The pointer of the curvilinear probe will pointing towards the patient's right. And again, we try to identify the IVC, the aorta, and the spine. So in this view, we can actually easily differentiate the IVC and the aorta, which I will show in the next clip. So here the IVC, okay, is more towards the patient's right, whereby the aorta more towards the patient left. Yeah, the shape is different. IVC is more elliptical, aorta more circular. And in terms of pulsatility, aorta is pulsatile, IV is not. In terms of compressibility, with gentle pressure, aorta will be compressible, whereby aorta is not. And the effect of on breathing, aorta will vary during respiration, whereby aorta will remain same. Okay. Right. So from transverse view, we move to the longitudinal view. Just rotate the probe. Okay, just rotate the probe 90 degrees, and the pointer will again pointing towards the patient head. Try to identify again these three main structure: the liver, the IVC, and the hepatic vein before we interpret. Okay. Uh, so let's have a look at another clip. Another way to assess a volume status is by doing the echocardiography or focus echo lah. But actually we're supposed to do as many echo view as possible to assess for the contractility, assess for the volume status before we comment on finding, but which is actually very limited in this presentation. So I hope that it will be a starting point for us to learn more about focus echo later on. But roughly for the subxiphoid view, or subcostal view of the echo is usually used as rescue view. So the principle on how to do this, basically the pointer will pointing towards the patient left. Okay, we tilt down. Okay, and then we try to get a view here, the liver, and wherever touch the liver is the right side of the heart. So this is, we have right atrium, right ventricle, left atrium, and left ventricle. Okay. So this is a clip showing a normal subxiphoid view of the heart. We can see that the contractility is just right. It's not hyperdynamic. The ventricle is not kissing with each other. Compared with patient with hypovolemia, very hyperdynamic LV. Okay, small chambers with very vigorous and hyperkinetic contraction, and the ventricles here is almost kissing with each other. Okay, so now let's move on to the methods on how can we test for fluid responsiveness. Basically, we have two main tests, whether to do passive leg raising test or giving fluid challenge or fluid boilers. Yeah. So the passive leg raising test basically involve elevating the patient's lower limb, okay, to increase the venous return, stroke volume, and cardiac output. And this is done by positioning the patient at 45 degrees semi-recumbent, head up, and then we tilt, to 45 degree legs up position, and we assess the patient back after about 1 minute. This maneuver will roughly transfer about 300 mils of the blood into the central circulation. And this method is actually good because it doesn't require additional fluid, and particularly for those patients who are poor fluid tolerance, such as heart failure or ESRF patient, this is a good test to do. Ideally it should be done in automatic motion bed and without touching the patient. Okay. Another way to test for fluid responsiveness is by giving fluid challenge, which is commonly used or commonly done. This is done by rapid administration of the crystalloid, about 250 to 500 mils of crystalloid rapidly, usually over 10 to 15 minutes. Sometimes we may give mini fluid challenge in poor fluid tolerant patient, about 100 mils bolus each, and then see the response. I'll move on to the next one. The limitation, this is extremely important. Measurement in ventilated patient probably has more predictive value as IVC variability is exaggerated in spontaneously breathing patients. So even in a ventilated patient, we do have, prerequisite. Usually it's said that we must have control mode. Patient must be synchronized with the ventilator with either volume about 6 to 8 mils per kilo, and we exclude any right heart failure, which is actually can be difficult in most of our patients. And another point is that there are multiple confounders that can affect the IVC size, such as the right atrial pressure, vessel compliance, position, as well as the abdominal pressure. So the measurement will be unreliable in patients with high right atrial pressure, such as those with cardiac tamponade or pulmonary embolism or tension pneumothorax. And in terms of compliance, in elderly, we know that the compliance will be low, so it does affect the measurement. And IVC does change with position. So generally, most of the time we do scan in supine position. Right? And study have shown that actually supine position makes the IVC size larger compared to when they are in the left lateral position. And also there's a effect of abdominal pressure. So increase in intra-abdominal pressure will subsequently reduce the IVC size and affect the affect the measurement or estimation. And again, most importantly, it's largely operator dependent. So we have to be careful about this as well. So as a conclusion, ultrasound is useful to evaluate the extremes. I would say that mainly for flat or fat. When we do scan, think of to differentiate whether this is flat or fat findings. So flat IVC with small hyperdynamic ventricles usually suggests hypovolemia, whereby bear in mind fat or pulmonary IVC doesn't always mean fluid unresponsive. So in the end of the day, clinical context is very, very important. So always incorporate the findings with clinical presentation when we interpret the ultrasound findings, okay? And we must always remember the limitations and to be honest, this presentation only meant to cover, the extremely basic information. And there's a lot more to cover here, especially on the focus echo, which actually can tell us a lot more information and can help us to to aid in our clinical judgment. So I hope this presentation will try to break the ice and spark the interest to learn more about the topic. Thank you. That's all. Thank you.